Good afternoon. Thank you for the invitation to give this talk. I'm really honored to be here. Talk a little bit about cardiac amyloidosis. As you well know, it's an infiltrative restrictive cardiomyopathy, which is caused by abnormal extracellular myocardial deposition of the misfolded amyloid fibrils. And there are two main types. One is caused by the monoclonal immunoglobulin light chain, and the other one by transthyretin, which is a serum transport protein. And it's again subtyped to wild type or senile, which is associated with aging, and mutant, which is caused by genetic variants. And cardiac involvement is very common, and the most common presentation is heart failure with preserved ejection fraction in elderly men. And heart failure occurs once enough amyloid is deposited and causes left ventricular wall thickening. And therefore, echocardiography would be the first screening tool in these patients with cardiac hypertrophy. And the features are thickened walls, biatrial enlargement, diastolic dysfunction. And diastolic dysfunction is the earliest abnormality, even before heart failure symptoms. Tissue Doppler enables more advanced tools, and we can assess myocardial strain, a measure of tissue deformation, strain rate, which are important for the assessment of systolic and diastolic function, and also predictors of death in cardiac amyloidosis. And we can also assess the longitudinal velocities, which are sensitive for the early detection of myocardial disease. And these are normally higher in lateral wall versus septum and higher at the base versus the apex, but as the disease progresses, there is severely impaired longitudinal shortening at the base with preservation at the apex, maybe because of preferential deposition of amyloid with apical sparing, or because of higher stress, remodeling and apoptosis next to the LV outflow. But there are similar patterns in cardiac amyloidosis in different types, and therefore we cannot differentiate with echocardiography between the different cardiac amyloidosis subtypes. And here you can see a case of normal and a case of cardiac amyloidosis with thickened myocardial walls and enlargement of both atria. And here is a case of normal strain, whereas in cardiac amyloidosis, you can see that the apical strain is preserved, and that's very characteristic. Now, in MRI, late gadolinium enhancement is the hallmark for the diagnosis of cardiac amyloidosis. It starts in the subendocardial region, but when it gets diffuse and when it involves also the atrial wall, it is characteristic of cardiac amyloidosis with a sensitivity of 80% and very high specificity of 90% compared to endomyocardial biopsy. Again, amyloid deposits are more prominent at the basal and mid cavity, and again, there is a gradient from base to apex. And here you can see subendocardial late gadolinium enhancement, and another very characteristic finding on T1, there is a reverse relationship between the nulling times of the myocardium and the blood. Here you can see no nulling. Here you can see nulling of the myocardium before blood. And then nulling of the blood and enhancement of the myocardium, and this is a characteristic of cardiac amyloidosis. Subendocardial T1 is shortened, and the quantitative assessment of cardiac extracellular volume on MRI is also very characteristic, although extracellular volume is not specific, but a very high extracellular volume is suspicious for cardiac amyloidosis. So with cardiac MRI, we can differentiate to some extent between the different types of cardiac amyloidosis because there's more extensive late gadolinium enhancement in ATTR, and the right ventricle free wall late gadolinium enhancement is also more prevalent in ATTR, but these patterns also overlap, so actually we cannot differentiate with MRI. And here is an example from this manuscript that shows that there is a relationship between late gadolinium enhancement and high extracellular volume. They correlate very well. And extracellular volume has been shown also to independently correlate with mortality in ATTR. So as we saw, AL and ATTR cardiac amyloidosis have overlapping imaging features on echocardiography and MRI. And on the other hand, we know that it's very very important to make the correct diagnosis. Also because there is a mild clinical presentation for ATTR, there is a different prognosis, and AL has worse prognosis, and also, and most importantly, the therapy is different because there are new therapies now for ATTR, specifically targeting the transthyretin protein. And the gold standard for diagnosis and subtyping is endomyocardial biopsy, but we know that this has its own limitations. It has been shown that technetium labeled biphosphonate localized to cardiac amyloid deposits, and the different tracer DPD or POAP or HMDP have been shown to have very good sensitivities and specificities, perhaps due to preferential binding to ATTR, perhaps due to higher calcium content, and also different binding to different mutation types, and DPD positive uptake in 97% of patients with type A amyloid, which is present in most mutations and also in the wild type. So these tracers have the ability to specifically identify ATTR non-invasively, which is very important. This is a very important study, international multicenter, in over 1,200 patients with suspected cardiac amyloidosis, and as you can see, the sensitivity is almost 100%. The study was negative in 77 out of 113 patients without cardiac ATTR, and this was due to light chain amyloidosis, but the specificity for ATTR when serum studies were negative was 100%. So does not pick up AL amyloidosis, but should be interpreted in context of serum studies. How do we perform the studies? Very easy to perform, rest only, no patient preparation, no contraindications. The test time is 1 to 3 hours, and the 3-hour imaging is likely better, more specific, and the radiation dose is about 3.2 millisieverts. The studies with DPD and HMDP are scored visually, and it's called a Perugini score, and it goes from 0, normal study, Perugini score 1, very little cardiac uptake. Perugini score 2, you have intense cardiac uptake with attenuated bone uptake, and score 3, you have intense cardiac uptake with a very low or no bone activity. And here the sensitivity and specificity were very high. Here again, a positive study and a negative study with no cardiac activity. Another way of looking at the studies is to do semi-quantitative assessment and calculating the heart to whole body ratio. The retention was higher in amyloid cardiomyopathy. This is, okay. Now here is an example of a patient with, you can see here, where is it? Stop working. Leg gadolinium enhancement, very low activity, so we wouldn't call it positive. However, we gave it a score 1, and this patient was diagnosed with familial TTR amyloidosis with this mutation, and interestingly in this work by the group from the Royal Free, they also present the same mutation with very low cardiac uptake. There is a strain pattern, there is transmural lead gadolinium enhancement, and also very low cardiac uptake in the same mutation. So this is a TTR mutation with low cardiac uptake. On the other hand, in this patient with known AL amyloidosis, you see relatively intense uptake, score 2, and we need to remember that up to 50% of AL amyloid patients have cardiac DPD or HMDP uptake. The median score is 1, but in some cases it can be higher. Quantitative assessment is also possible, and there are quantitative packages of the companies GE and Siemens where you can actually get the SUV. We also have validated this method, and we get a very good separation between Perugini scores 2 and 3 and 0 and 1. Here the separation is less good, perhaps because we didn't have enough patients with Perugini score 1, and this needs to be further assessed. In PYP, which is more prevalent in the US, you also have you can also have same scores of 1 to 3, and here, heart to contralateral lung ratios are calculated. I'll show you in a minute a slide. And if it's 1.5 or greater, it's classified as ATTR, and if it's less, it's negative. Or you can also look visually, and if it's 2 or greater, which is equal to or greater than a rib, then it's ATTR positive, and otherwise it's negative. But again, any degree of POP uptake can also be seen in AL, so a complete evaluation is needed. This is an example how the score is obtained. And also here you have the degree of, you have apical sparing, just to show you. Can be used for screening. Just want a small word about amyloid binding PET tracers. They bind to cardiac amyloid, but you cannot differentiate because they bind to both types. And the amyloid binding SPECT tracers, the performance is poor in cardiac amyloidosis. 2 words about MIBG. There's a high incidence of myocardial denervation, and reduced MIBG uptake and cardiac denervation occur early and earlier than amyloid deposits are detected by bone tracers. But again, the differentiation between AL and ATTR is not possible. It can be used for prognosis because the heart to mediastinum ratio less than 1.6 indicates poor prognosis also in these patients. So just to summarize, echo and MRI have overlapping imaging features and unable to differentiate between different types of cardiac amyloidosis. Technetium-labeled PYP, DPD, and HMDP are highly diagnostic for ATTR when serum studies are negative, and in this case, no biopsy is required. Early diagnosis can be used prior to clinical symptoms, and technetium-labeled tracers are potentially suited, iodine 123 MIBG, even earlier, and this may allow targeted therapy and improve outcomes. Is there a role in screening? There may be. And there are new therapies which will require quantitative assessment for disease monitoring, so quantitative SPECT or quantitative PECT may become very important in the near future. Thank you very much for your attention.
Thank you very much for your exhaustive review on cardiac amyloidosis, telling us the use of imaging techniques in differentiating, because it is now potentially treatable by some drugs are coming. I think these tests are very, very important. Thank you very much. Anybody would like to ask?
As incidents of cardiac amyloidosis come down and increase, because when we are all students, we see a lot of amyloidosis. We have never seen amyloidosis in the open, but cardiac amyloidosis. Is it because of the chronic infection being less nowadays? Amyloidosis are less than what it used to be.
Yeah, I don't know. I just know that it's a very popular topic now. Research they've been using it in screening populations with carpal tunnel syndromes, patients with aortic stenosis, or with any types of heart failure. It's supposed to be about.
You do any endobiotic biopsy regularly?
It's being increasingly recognized in our country because of imaging techniques and all. Yeah. This MRI, etc., has suggested quite a bit. So, and the aging population is also there. So, it's being increasingly recognized. We are seeing number of patients. Thank you. Yeah, but I think this is important to find out the AL or the ATTR type, because they are potentially treatable. Thank you.
Yeah, thank you, Dr. Simona bin Haim, and may we request the chairpersons to present the memento and certificate to Dr. Simona bin Haim.